We go on to the next talk by Dr. Partha. Does not need an introduction. Chairman of the Scientific Committee AIOS, a very popular speaker, regular visitor to Kerala State Conferences. Dr. Partha will speak about cataract after refractive surgery. Over to you, Doctor.
Thank you very much. Thank you, Sai. Thank you, Kerala Ophthalmic Society. And I'm really grateful for having such a wonderful session in the morning from which I learned so much, and we'll emulate it in our future conferences. So coming to the post-refractive surgery after for phacoemulsification, and if there is a patient who has had refractive surgery, so what are the challenges there? So the challenges are very, very unique to the cataract surgeon, and this patient has been used to a spectacle independence, and at times, even after cataract surgery, he wants that total, absolute spectacle independence, which is a very unrealistic expectation. And from the surgeon's point of view, we have formulae, but they are not absolutely accurate. So this is what gives to the refractive surprises, because the traditional formulae lose their accuracy in these patients, because for the myopic refractive surgery patients, they can end up with hyperopia post-refractive, post-operative, and a hyperopic can end up with myopia. But what are the sources of error? And these are the keratometry, the most important source of error, because as we know that what measurements have been taken are from the central 2.5 to 3 millimeter zone. And this has been flattened by the keratorefractive surgery. So here we have an assumption which does not hold true. And thereby there's an overestimation of nearly 15 to 25%. And also the curvature of the anterior and the posterior cornea is altered, and the assumption of a refractive index of 1.3375 is absolutely fallacious. So the errors in the formula, the newer generation formulas utilize the relationship between the K and the ACD to estimate the ELP, and all these have a false shadow ACD leading to an anterior ELP, and thereby an underestimation of the intraocular lens power, and thus a post-operative refractive surprise. So what are the formula that we currently use for these patients? That's the ASCRS online. It is very, very freely accessible, and multiple formulae are available. And also an average formula is well displayed. The tomography, it's very, very helpful in assessing the anterior as well as the posterior corneal curvature, and the intraoperative aphakic calculation. Now, I wish to dwell on this point, and it's a very simple technique. It's a very important technique, and this is an on-table retinoscopy in the patient undergoing the cataract surgery after the cataract has been removed, and he is lying in that aphakic state. So it just takes a little while to do an intraoperative retinoscopy, and an aphakic aberrometry can also be done, but this is very difficult and very expensive. Limitations, of course, is the intraocular pressure, the patient fixation, and the pressure of the speculum. But yet, it will actually prevent a post-operative refractive surprise. This is my senior-most optometrist who is doing this aphakic refraction on the table. Just takes him about 30 seconds to 40 seconds to do it. And then we have a value that is actually going to be very close to the actual value. So if you have the calculations, and I'm going to show you in a few next slides, that if you have the calculations done online by the ASCRS formula, then you need to tally it. Why? Because there can be errors. Preoperative counseling is very important and of paramount importance, and the expectations of the patient has to be tempered, and especially because of the spectacle independence. The presbyopia correcting IOLs may not be the correct choice in these patients, and this has to be explained in detail, and there could be an irregular astigmatism for these patients. So the intraoperative challenges, what they can be, and this is a post-RK eye, and in a post-RK eye with so many incisions, you will expect a cylinder power, small or large. So the corneal incisions have to be avoided, and thereby you have to make a scleral tunnel in these cases. Otherwise, the corneal incisions will all open up like an orange. So 8 incisions of RK, and the creation of the corneal incisions, if the side port needs to be created, it can be created in between the RK incisions, but best again scleral. So once the phaco has to be performed, and it has to be under very, very low parameters, the rexis is not very difficult, but the incision is very, very important, and a pre-operative counseling regarding the astigmatism is important. It's important not to give a toric IOL in these patients, because in such patients, a toric IOL might not be the best IOL. The toricity might change in due course. So the opening up of the RK incision is a possibility. Now I'll just show you a mystery case. Now this was a 43-year-old lady with cataract grade 2 and had come in, and all the biometry calculations had been done. Then later she came in and said that she had some sort of a surgery many years ago, and so she did not want to tell this in front of her husband, who had accompanied in the first time. So this, we went, and then we further did a pentacam for this patient, and we did see that there was a flattening in the pentacam. So we went on ahead and did the calculations, and this was the calculation that we deduced. And you can see that even if we took the flattest K, what we came to through the calculation was this was the ASCRS online, and they suggested 12 diopters. Whereas when we took finally the calculation by our optometrist, and he suggested 15 diopters, and we took it at 15 diopters, and this is what we had the result of. So this result was very, very much in matching, and you can see the small cylinder in place, and nearly a very, very small spherical power post-refractive surgery. So this is the importance of going by the actuality of on-table retinoscopy for the patient. So post-LASIK phacoemulsification, and of course you have to be cognizant of the fact that the flap and the hinge need to be protected, and they should not be disturbed. It's important. And this is a small video. If we have time, I'll just go through the video in short. This was a patient who underwent a phakic IOL, and then again, after 4 months, had a retina detachment. Now this retina detachment, we had a few holes which we had lasered earlier, and they were well sealed quite long before the phakic IOL was done. But the patient developed a retina detachment after 4 months only, and had to undergo a retina detachment surgery. So once the retina detachment surgery was done, so again, about 3 months later, this was what was happened. So there was a lens touch, and our retina surgeon said that there was a lens touch in this case, and we had what was nearly an intumescent cataract here. We had to remove this lens. We had to remove the phakic IOL, which is not so difficult, but it has to be done hand over hand and very, very gradually. And once the phakic IOL is removed, then the next part is doing a good cataract surgery in this patient. You will remember that there was a little bit of synechia, and I was expecting some complications in this patient. So when we took out we milked out the little bit of cortical matter after putting in the cystotome, we did have a problem. And so we were very, very tenderly going ahead with the capsulorhexis, but it was not doing fine. And ultimately, the capsulorhexis went out, not in one place, but in 2 places. And once it was out, then again, the iris was shrinking. So we had quite a lot of trouble. And once we got the cortical matter out, what we did find is there was a thick plaque, and that's where the lens touch was there. In the previous surgery. So we had to do something about the plaque, but before that we placed a 3-piece lens. We don't know if it went to the sulcus or if it went to a partial bag, because it was an open bag, so a 3-piece lens would be the best choice in this case. So we placed this 3-piece lens, and then we had to do something about that opacity. So we went in with the MVR knife, and centrally we punctured the opacity, the plaque. And after that we did with the vitrector, we went ahead, and under cover of viscoelastic, we removed a small part of the central opacity. So that's approximately 2.5 to 3 millimeters that we could remove, remembering the fact that if we went beyond the opacity, then there might be a run out even in the posterior capsule. So we had to be very careful. God willing, it did not run out, and we could leave the IOL in place nicely and safely. Patient did get back better vision from what obviously was enjoying, but it was definitely suboptimal. It was approximately 624 by N18 is what the patient got back. So the post-operative challenges are some small residual refractive error can be managed with glasses or contact lenses. For larger refractive errors, LASIK or PRK may be offered if the parameters do permit. A piggyback IOL is also a possibility. IOL exchange is an option, but of course for those very, very large errors. Thank you very much for your patient hearing.
Thanks a lot, Partha, for covering such a complex topic in such a short time. I think just to summarize, ACRS calculator is the main problem here is how to get calculate the intraocular lens power. And as Partha has mentioned, ACRS calculator is the go-to site for calculating these powers. And you don't really have to have an array of diagnostic equipment. Whatever equipment you have, you can just fill in those those variables, and the calculator will come out with formulas which use those variables to give you the IOL power. Counseling has to be very, very important, because sometimes you may not really be spot on, and the patient must be aware that it is a complex situation, and it is actually sometimes a shot in the dark. So,
Thank you, Dr.